So this presentation is going to be on medication management and opioid use disorder. Synopsis of the problem: there's no question that the opioid epidemic is still on the rise and still continuing despite COVID. But in 2018, there were over 67,000 people who died from opiate overdose, and in 1999 to 2018, close to 450,000 people died from opioid overdose. That includes prescription, non-prescription, any type of opiate. The Centers for Disease Control and Prevention described it in 3 waves, with the first wave beginning with an increase of prescribing opiates. So in the 1990s, doctors were told by pharmaceutical companies that these opiates were not addicting, great for pain, prescribe them for such, which doctors were doing. And then that just kind of became the thing. The second wave began in 2010 with rapid increases in overdose deaths involving heroin. So the kind of progression of opioid use disorder, a lot of times they start out with using opiates, whether it's prescribed or not, but pills basically that were at one point a prescription for somebody. And as it progresses, they tend, as your tolerance builds, they tend to use more pills, which gets more expensive. And so they progress to heroin eventually, most of the time because it's cheaper and sometimes it's easy to access, more so than getting a prescription or trying to find a prescription from somebody to purchase. Heroin seems to be a little bit more accessible. The third wave began in 2013 with significant increases in overdose deaths involving synthetic opioids. So that means like the methadone, tramadol, things like that. Fentanyl, that has been, still continues to be a huge thing. In my county where I'm at, I see fentanyl. I work in an opioid treatment program. I see fentanyl in UAs constantly, and it's bothersome, it's worrisome, because a lot of these people, when I inform them like, hey, I got your UA back and it has fentanyl in it, they had no idea. And so then we have that discussion of how dangerous fentanyl could be, that it only takes a minimal amount of fentanyl to be fatal. And so sometimes it scares them, sometimes it doesn't. Statistical data, 130 plus people die each day from opioid overdose. This means prescription or illicit use. 10.3 million misused prescription opiates in 2018 alone. So this means they were prescribed it, they sold it, or they took more than they were supposed to, things like that. So 808,000 people used heroin in 2018. 81,000 people used heroin for the first time in 2018. So kind of going back to, like I talked about earlier, the progression of opioid use and building your tolerance, your, finances. You're not going to have enough money to pay for pills anymore. So the next thing would be going to heroin. 2 million people diagnosed with an opioid use disorder in 2018. All this information here was derived from the U.S. Department of Health and Human Services website. So some arguments for medication management, which is Suboxone, methadone. 4, it helps pregnant women work on obtaining an OBGYN, working with CPS, abstaining from illicit opiates. So a lot of times pregnant females who are using heroin don't have the best prenatal care. And so with or without the threat from CPS, they tend to come on the program, and they their goals are obtaining a doctor, primary doctor for this baby, for themselves, and to kind of sometimes appease CPS restrictions. So another thing, it reduces the risk of HIV in the community. People are using less. They might still be using, but they are using probably significantly less, which means less needle use, which means less risk of transmitting HIV, also less risky behavior, things like that. So it helps the individual overcome withdrawal and focus on gaining stability in life. I have seen multiple people on my caseload who have started the program, have gotten stable on their dose, who have gotten jobs, gotten housing, gotten their kids back because of methadone or Suboxone, because that's what they needed to give them that hop to better their lives. Another thing it cuts crime and incarceration down. So when people aren't having to go out and steal to find their next fix because they have the methadone, the medication, then it cuts the crime and incarceration. So some arguments against it takes away accountability for the individual to work at their recovery. So I'll explain more in the next slides, but a lot of professionals believe that the individual needs to completely remain 100% abstinent from any type of substance, not realizing that this is kind of a medication that they need, that their brain chemistry has changed, and that this will help them better their life. Synthetic opioids, methadone, can be just as addictive as standard opiates. So this is one thing I explain to individuals on the program during intake and assessment, is that methadone is synthetic and it does have the ability to create a dependence. So it could possibly do that. It can be misused and has a high street value. And some professionals don't believe in medication management harm reduction. Oppositional talking point 1, Suboxone and methadone, which are used to treat opiate addiction, both have a street value. In my city, Spokane, individuals will pay $1 per milligram in methadone and approximately $4 per milligram in Suboxone. Some of them are getting medication at no charge because they're on Medicare or Medicaid, which the state provides their treatment for free and their medication. So they're making money sometimes off of it and using it for other substances or whatever. Both can be misused, so Suboxone and methadone can be traded or sold for drugs or to keep a drug dealer supply up, because dealers will actually trade or sell or whatever these medications. They can be addicting, like I talked about. Poor impulse control in individuals with opioid use disorder does lead to increased crime. So like I said before, if they're still using and they don't have the impulse control and they've maybe been using more methadone or misusing their methadone and their tolerance has increased, they're probably going to go out and commit crimes to get whatever they need to make themselves feel better to avoid withdrawal. Talking point number 2, like I said, not taking accountability for their recoveries. Some people do believe that methadone, Suboxone is a crutch and that they won't be willing to work fully in treatment. Some believe that medication management encourages the addict to continue using. So kind of just giving them that supply of, hey, here's this free medication that we're going to give you that we can prescribe you, because you can't get prescribed it from your doctor because you've been red flagged for asking for opiates, but we'll give this to you for free and you can do with it what you want. So that's kind of another oppositional talking point as far as that goes. Thank you.